डेफ ब्लाइंडनेस है क्या, दूसरे डिसेबिलिटी से ये किस प्रकार अलग है। जब हम एक डेफ ब्लाइंड चाइल्ड की बात करते हैं, what is the uniqueness of a deaf blind child, what are the needs, what are the challenges, what are the ambitions, aspirations of a deaf blind child. Deaf blindness, just as the name suggests, it is about two disabilities. Primarily it is about deafness and blindness. Deaf blindness is also sometimes called dual sensory impairment, यानी दो senses, देखने के और सुनने के दोनों senses affected होता है. It is a unique disability which brings enormous challenges to the individuals and those who support them. Obviously जब हम एक मेजर सेंसेस की जब हम बात करते हैं और दोनों इफेक्ट होता है, तो चैलेंजेस, जो समस्याएं हैं, वो काफ़ी हद तक बढ़ जाता है. डेफ ब्लाइंडनेस एक यूनिक डिसेबिलिटी इसलिए है क्योंकि जो हमारे मेजर सेंसेस है फॉर लर्निंग एंड फॉर गेनिंग इंफॉर्मेशन, एक है हम देखते हैं और दूसरा है हम सुनते हैं. देखने और सुनने से हमको ऑलमोस्ट 95% ऑफ व्हाट वी लर्न एज अ चाइल्ड बिफोर 3 years of age comes through we hear and what we see. So naturally when both hearing and seeing is, it is important to know that the vision and hearing are the two disciplines. यहाँ बैठे बैठे भी हमको आगे क्या हो रहा है वो दिख रहा है, या में रहते हुए भी अगर बाहर से एक आवाज़ ज़ोर से आएगी तो हमको शायद सुनाई देता है और चलता है कि हमारे वातावरण में क्या हो रहा है. बट द मोमेंट दीज टू सेंसेस आर अफेक्टेड, इट सो हैपेंस दैट द वर्ल्ड बिकम्स अ मच narrower, a much isolated, much smaller place, and that is the uniqueness of deaf blindness, and that is why the challenges, the difficulties of deaf blind people is much more magnified, much more complicated than just visual impairment or hearing impairment. Of course, people rely upon information about the world around them in order to learn, function and interact. कोई भी चीज़ हम करना सीखना चाहते हैं, किसी भी व्यक्ति से हम बात करना चाहते हैं, अपनी बात को सामने बताना चाहते हैं, it is because of the information that we receive. Vision and hearing are the major senses through which we access information, and persons who have vision and hearing loss, their access to information is affected, is majorly affected, which is why the world becomes a narrow place. एक तरह से deaf blindness is also known as the access disability. Deaf blindness is called as an access disability purely because their access to the world, जब मैं access to the world is affected बोल रही हूँ, I don't want to limit myself to their physical access. Yes, of course their physical access is also limited because they have mobility problems, they have difficulty from moving from one place to another, but that's not primarily because of their physical disability. It is primarily because they cannot see and hear where they are going. अगर हाथ अपने फिंगर टिप से आगे कोई चीज़ है तो इट इज़ एज गुड एज इट इज़ नॉट देयर. जो चीज़ अपने हाथ के डायमीटर में उनके स्पर्श में आए, दुनिया वहाँ तक सीमित है, और जहाँ कोई चीज़, कुर्सी, टेबल, इंसान अगर अपने हाथ के दायरे से बाहर चले जाए तो फिर वो एक आइसोलेटेड वर्ल्ड हो जाता है, एंड दैट इज़ व्हाई इट इज़ नोन एज अ एक्सेस डिसेबिलिटी. अगर हम समझना चाहें कि डेफ ब्लाइंडनेस एग्जैक्टली उसमें एलिमेंट्स क्या क्या है, सबसे पहले तो अ डेफ ब्लाइंड पर्सन इज़ वन हु हैज़ बोथ डेफनेस एंड blindness happening together. It has to happen simultaneously. Sometimes deafblind people may also have other disabilities, which makes it even more complicated. They might have mental retardation. Deafblind children could also have cerebral palsy. They could have physical disabilities. They could also have autism also. It just makes everything so much more restrictive. It makes everything so much more limited, and the child is left so isolated. Access to information is limited, and therefore communication becomes the biggest challenge. Communication यानी यहाँ पर मैं सिर्फ I'm not talking of only talking as in speech communication, but even their communicating their gestures, communicating their needs, interpreting what the other person is trying to say is becomes very, very difficult for them. Moving around is difficult because of course क्योंकि they are in their own world, they are always isolated, staying within their own world. Therefore एक तो एक इच्छा, एक motivation to move around is limited, but also the world becomes a very dangerous place for them to move around, because कहाँ कुर्सी, टेबल, रूम, दरवाज़ा, लोग कहाँ पर है, they will bang against it, fine, but that's a safety issue, but also when they bang against it, they might not get the right information कि किसके against वो bang किए. कुर्सी और टेबल दो अलग चीज़ है, वो जब तक वो एक्सप्लोर नहीं करेंगे, जब तक वो जानेंगे नहीं, तब तक वो ये नहीं पहचानेंगे कि एक वस्तु दूसरे वस्तु से अलग है. एंड देयरफॉर देयर वर्ल्ड बिकम्स मोर रेस्ट्रिक्टेड इन टर्म्स ऑफ देयर मूवमेंट एज वेल. एंड देयरफॉर दे ऑल्सो नीड इंटेंस सपोर्ट इन ऑल देयर नीड्स. कुछ भी वो काम करना चाहे, चाहे वो खाना खाए, चाहे वो अपनी रोज़मर्रा के जो काम है, ब्रशिंग हो, बेदिंग हो, फॉर एवरीथिंग दे नीड अ लॉट मोर सपोर्ट, अ लॉट मोर टाइम, अ लॉट मोर information and a lot more patience, of course, that you communicate to them throughout the process. You help a deafblind child understand what is it exactly that he is going through when he is eating, that he is not the only one eating. जब आप खाते हैं, you are also moving your jaws. Help the child touch and feel. अक्सर बच्चे पेरेंट्स कंप्लेन करते कि हमारा बच्चा खाना चबाता नहीं है, but that's because he has never खाना मुंह में डालकर दूसरे लोग चबाते हैं. That becomes even more limited. He might have physical problems or chewing, swallowing problems, but the major reason is that information that खाना मुंह में डालने से चबाना होता है, that's missing because he's never seen a person, he's never experienced that other people also take food into their mouth and chew. And therefore they are left to the reflexes कि खाना मुंह में तो reflexively वो उसको swallow कर दिया. That kind of intense support they will need in their everyday activities. It affects all round development. एक favorite example मेरा यहाँ पर है that अक्सर लोग confuse करते हैं कि अगर डेफ ब्लाइंड बच्चा है तो एक विजुअल इम्पेयरमेंट या एक ब्लाइंड स्कूल के क्लासरूम में एक स्पीच थेरेपिस्ट को हम भेज दें तो उसके जो ब्लाइंडनेस और डेफनेस दोनों की नीड्स पूरे हो सकते हैं. या डेफ ब्लाइंड बच्चा अगर एक डेफ स्कूल में है, एक ब्रेल इंस्ट्रक्टर, एक मोबिलिटी इंस्ट्रक्टर को भेज दे तो उसके डेफ ब्लाइंड नीड्स टोटल उस मीट हो सकते हैं. ऐसा नहीं है. डेफ ब्लाइंडनेस itself presents very complicated issues and it affects development in totality. Communication becomes severely affected. Opportunities to interact is very limited. Opportunities to interact लोगों के साथ becomes limited, but also not just with people, even with objects. Exploration with objects also becomes very limited. Ability to move around is very restricted, as I just explained, and they need help in very simple day-to-day activities also. They need a lot of help. Usually a deafblind child will benefit from a highly structured educational or a rehabilitation program. It's about a very structured, a very well thought over, a very sound educational program where the educational environment includes the deafblind child at the very center, and people around the educational environment are aware of this child's changing need. It is a developmental concept and not a medical concept. आपको किसी भी डायग्नोसिस में आपको डेफ ब्लाइंडनेस नहीं मिल सकता है. WHO के क्लासिफिकेशन में डेफ ब्लाइंडनेस नहीं मिल सकता है. ICF के क्लासिफिकेशन में डेफ ब्लाइंडनेस नहीं मिलेगा आपको. इट्स अ वेरी डेवलपमेंटल कॉन्सेप्ट. आपको ये सारे जो स्टैच्यूटरी क्लासिफिकेशंस है उसमें विजुअल इम्पेयरमेंट एंड हियरिंग इम्पेयरमेंट के क्राइटेरिया और कैरेक्टरिस्टिक्स और डेफिनेशंस मिल. बट when it is put together, it is always, even now, there is no diagnosis as deaf blindness. To diagnose a child, we still have to do the vision tests, we still have to do the hearing test. Therefore, we still have to rely on the clinical characteristics of visual impairment and hearing impairment. But when it is found together, then as I explained that the disability becomes a new disability. Therefore कई जगह confusion खास करके हमारे country में होता है कि इसका level क्या है, deaf blindness के range क्या है, severe क्या है, moderate क्या है. ऐसा कोई range इसमें नहीं है. severe, moderate, mild, moderate कोई range नहीं है. Similarly हम ये नहीं बोल सकते हैं कि he is 30% deaf blind or he is 100% deaf blind. But we can say that he has this much vision loss and this much hearing loss, and therefore the child is a deaf-blind child. What are some of the characteristics of deaf-blind children? By now you would have understood that communication becomes the major challenge for deaf blindness, for a deaf blind person, and therefore difficulty in establishing and maintaining interpersonal relationship, चाहे वो अपने फैमिली मेम्बर के साथ हो, चाहे वो अपने स्कूल टीचर्स के साथ हो, चाहे अपने एज के बाकी बच्चों के साथ हो. Maintaining a relationship, understanding that there is another person and that person is my mother or my younger brother or my teacher, that becomes very difficult for these children. दे लैक एंटिसिपेशन. एक फेवरेट एग्जांपल यहाँ पर मैं ये बताऊँगी कि हमेशा हमारे बच्चे, डेफ ब्लाइंड बच्चे, दे लिव इन अ वर्ल्ड ऑफ मैजिक. Why magic? Because a sighted hearing child, when this child cries, the child sees कि मदर जो एक नॉर्मल आम 6 महीने का बच्चा जब रोता है तो क्या होता है, मदर जो है वो सामने आती हैं, देखती है, शायद गोदी में उठाती है बच्चे को, शायद बोलती है कि भूख लगी है, दूध पीना है, लिटा के जाती हैं, मिल्क लेकर आती है, शायद अगर बॉटल में मिल्क गर्म है तो थोड़ा शेक करती है, थोड़ा ठंडा करती है. और ये सारा जो एक्सपीरियंस है दिस 6 month old child is seeing. Even if the child is crying louder and louder, it is because the child is anticipating that the milk is coming for me. So एक तरह से कॉग्निटिव डेवलपमेंट, एक लर्निंग उस बच्चे को 6 महीने में ये हो रहा है कि मेरे रोने से दूध मिलेगा मुझे. Imagine a deaf blind child in that situation. The child is crying. Sometimes the child cries because the child is wet. Sometimes the child cries because the child doesn't have milk, is hungry. Sometimes the child cries because he just wants to be picked up. कभी तो कोई गोदी में उठा लेता है, कभी कोई अचानक से दूध का बॉटल मुंह में लगा देता है, कभी कोई कपड़ा पलट देता है, बच्चे का कपड़ा चेंज कर देता है. What is going to happen next to this child? This child is missing all these experiences, and therefore it's as if the bottle of milk is appearing from magic and disappearing into magic. So this child is left alone at a receiving end, that I cry and sometimes something happens, I don't know what's going to happen next. It's a world of magic for our children, but in a way it's a very serious consequence of deaf blindness, that they lack anticipation about what is going to happen next to them. Many children have sleep प्रॉब्लम्स एंड अदर मेडिकल प्रॉब्लम्स. रात को सोना मुश्किल होता है बच्चों को, या फिर कई सीरियस और मेडिकल इश्यूज़, हार्ट प्रॉब्लम्स हो सकते हैं, ब्रीदिंग डिफ़िकल्टीज़ हो सकते हैं, एपिलेप्सी डिफ़िकल्टी हो सकता है, या फिर अगर कोई जेनेटिक कंडीशन है तो उसके साथ कई मेडिकल प्रॉब्लम्स भी और आ सकते हैं. एंड देयर इज़ अ डिले इन ओवरऑल डेवलपमेंट. अगर हम मोटा 3 एरिया देखें जिसके ऊपर सबसे ज़्यादा इम्पैक्ट डेफ ब्लाइंडनेस का पड़ता है, दैट इज़ अबाउट कम्युनिकेशन, it is about development, and it is about their educational problems. Therefore these are the 3 major areas. और इसके तहत बाकी सब, आपका मोबिलिटी हो, आपका सेंसरी ट्रेनिंग हो, बिहेवियरल इश्यूज़ हो, सोशल इश्यूज़ हो, ये सारा कुछ इसके ये 3 मेजर फ्रेम्स के अंदर ये आ जाता है. So who are deaf blind children? In functional terms, these people may include those with moderate to profound auditory and significant visual impairments. They might have moderate auditory impairments, they might have more severe or profound impairments also. They might be moderate to profound auditory and significant visual impairments with other significant disabilities. So deaf plus blind plus other disabilities. They might have central processing problems of vision and hearing. I must repeat over here, कई बार, or 30% of our children, deaf blind children, if you take them to an ophthalmologist or if you take them to an ENT or an audiologist, then you may not get a proper clinical diagnosis of visual impairment or hearing impairment. You might still come back with normal vision and normal hearing diagnosis. There is a high chance that they do not have any obvious visual or hearing disorders. Disorder is at the level of their brain, at the processing level, and therefore even if their visual functions are intact, their hearing functions are intact, the brain is unable to process that information, and therefore that child will need intervention for visual stimulation and hearing stimulation. There could be progressive sensory impacts. ज़रूरी नहीं है that the child is born and stays with that particular level of sensory loss. Over a period of time, the sensory loss might deteriorate. It might also improve. There could be some kind of changes in the sensory loss. A significant visual impairment and a possible loss of auditory processing mechanisms associated with severe physical disability or severe cognitive disability and severe communication delay. Let me just explain this. कई बार children are born with a very clear visual impairment and you can diagnose it. But sometimes you cannot diagnose the hearing loss, you cannot diagnose the hearing impairment or hearing problem. Yet these children do not speak, yet these children do not develop language. Sometimes these children also can be functionally defined as deafblind children because of the visual impairment and their language delay and their speech impairment. Although the hearing is normal, they are unable to process the information and therefore will benefit from a program that caters to other deafblind children. That it is not a medical concept, it is a developmental concept, and you can see from this information why it is a developmental concept. हम विथ फाइनलिटी ये नहीं बोल सकते कि इतना विजुअल इम्पेयरमेंट और इतना हियरिंग इम्पेयरमेंट होने से ही ये डेफ ब्लाइंड बच्चा है. देयर कुड बी डिफरेंट रेंजेस इन दैट. समटाइम्स इट मे नॉट इवन बी डायग्नोस्ड, but yet functionally when you work with it, it seems to be like a processing disorder, and therefore that child also can be defined as a deafblind child. So what are the different ranges of deafblind people? It could be a person who is totally deaf with partial vision, so there is total hearing loss with some kind of vision left. It could be a person who is totally blind, total visual loss, no light perception, with some kind of partial hearing remaining. It could be a person with some partial hearing and partial vision also. So it's not just about total loss but partial vision and partial hearing as well. And finally, it could be a person who has total deafness and total blindness. I would like to say here that of the world prevalence rates of deaf blindness, only 5 to 7% of deafblind people are totally deaf and totally blind. Almost 93 to 95% of the deafblind population has either some amount of vision remaining or some amount of hearing remaining, or both some kind of vision and hearing remaining, which means that as educators, as professionals, it is our responsibility to harness the remaining vision and hearing, to harness the remaining potential, to maximize the remaining potential, and never make the mistake that a deafblind child means he cannot see and he cannot hear and therefore just focus on the touch. So the whole range is present, and very few will be actually those who have no vision, meaning no light perception at all and no hearing at all, and they of course will need a lot of touch based intervention. Congenital conditions are those that are present at birth, meaning a child can be deafblind from birth. Adventitious meaning a child who acquires deafblindness later during childhood. And therefore, there are two types of congenital deafblindness and acquired or adventitious deafblind. If this is about deafblindness, then what are the major needs of deafblind children? One must assure information is accessed by deafblind children. That's the primary mantra. अगर हम कहें कि एक एजुकेटर को, एक स्पेशल एजुकेटर को, या एक इंटरविनर को, या एक CBR वर्कर को, या एक पेरेंट को, प्रोफेशनल को एक डेफब्लाइंड बच्चे के साथ काम करते समय किस चीज़ को ध्यान में रखना है? रूल नंबर 1 इज इंटरप्रेटिंग एवरी इंफॉर्मेशन for the deafblind child, making sure that the deafblind child is accessing the information in the immediate environment. And that can be done through a variety of ways. The variety of communication methods that are used could be through touch, by touching things around, could be through exploring objects, it could be through simple body movements, our body movements, and the child touching our body movements to understand what it communicates. It could be through sign language, it could be through braille, it could be through writing on the deafblind child's palm, which is called print on palm. It could be through finger spelling, it could be through writing on paper, and there are multiple other ways of communicating with deafblind children. One other common misconception is that deafblind children do not speak, that all of them need sign language. That's not quite true. Some deafblind people are able to articulate very well, especially those with acquired deafblind condition who have had some kind of language before the age of 3 years and have lost their hearing later in their childhood. They are able to articulate, but they might depend more on lip reading, or they might depend on you writing for them and they seeing it and then articulating it through speech. So there is a whole range again over here. Moving on to causes of deafblindness. What are some of the major causes? डेफ ब्लाइंडनेस में ऐसे कोई खास कॉज नहीं है जो बाकी डिसेबिलिटीज़ के लिए वो कॉज नहीं है। जैसे आमतौर पर हम इंटेलेक्चुअल डिसेबिलिटी या सर्बल पॉलिसी या इवन विजन एंड हियरिंग इम्पेयरमेंट की बात करते हैं, जो मेजर रिस्क फैक्टर्स दूसरे डिसेबिलिटीज़ के लिए है, वही सारे रिस्क फैक्टर्स डेफ ब्लाइंडनेस के लिए भी हैं। कुछ ऐसे कॉजेज है जो स्पेसिफिक टू डेफ ब्लाइंडनेस है, विच आई विल हाईलाइट हियर एज अ प्रीनेटल कॉज. व्हाट आर सम ऑफ द कॉमन इन्फेक्शंस? Number one cause is rubella, and rubella in the developing countries, particularly in India, continues to be the major cause of deaf blindness. Some of the specific causes of deaf blindness is related to genetic disorders. Many deafblind children are born due to the genetic conditions. Some of these are very rare syndromes, but increasingly with more advanced medical research, with more advanced medical technology, these children are surviving. For example, Down syndrome. हम जानते हैं that Down syndrome is related to intellectual disability, but almost 30 to 40% of Down syndrome have both vision and hearing loss. Charge association is another very complicated condition where charge each of the letter of charge stands for one condition, like coloboma of the eye, heart disease, atresia, that is closing of the ear canals, of the nose canals and the ear canals, retarded growth, very small for their age children, genital hypoplasia where the private parts are not completely formed, and ear anomalies, meaning that the ears are very odd shaped. So, and this is a genetic disorder. You see a child with charge, he might have 3 or 4 of these conditions, and you know visually just observing that probably this is a charged child and he needs to go for a genetic test. Similarly, other syndromes like golden hair, Tourette's, Lawrence-Moon-Biddle, Nouri syndrome are some of the other common syndromes, and these needs to be properly screened through a genetic test. Other trauma issues like fall, radiation, effect of drugs, pollution could be some of the other issues relating to deaf blindness. ड्यूरिंग बर्थ इश्यूज़, इंसिडेंटली जितने भी हमारे पास डेटा अभी तक इंडिया में हैं, वी फाउंड दैट मोस्ट ऑफ आवर चिल्ड्रन हैव acquired deaf blindness right at the time of birth, and that's because of lack of access to proper health care. It could be due to prematurity and lack of proper health facility for the newborn infant due to the premature conditions. It could be due to retinitis pigmentosa or congenital rubella which goes undetected. It could be due to birth jaundice. It could be due to retinopathy of prematurity, which is because of high or low amount of oxygen given to the child at birth, or breathing difficulty, low birth, prolonged labor, or any other kind of birth trauma. Could be children who are born blind and who acquire deafness at a later stage, or there could be children born with absolute normal vision and hearing, but due to some kind of accident or genetic issues, they might acquire both deafness and hearing, both deafness and blindness at a later stage. If it is a congenitally deaf-blind child, what are some of the key issues that we need to keep in mind? Remember that it is a child who is born with vision and hearing loss. Again, as I explained, the range could be completely different. The family gets the first setback. The family is in complete shock, in complete trauma, and therefore that is the time where we need to probably focus first on the family in helping them to deal with the situation. As a result, no bonding with the child takes place, or the bonding is very limited between the mother and the child. Interaction with the child is very limited because the family is going through their own grieving process. The child is withdrawn and lacks motivation. It has no clue as to what is happening around. Parents are very frustrated at that level, and the child from a very young age starts to develop some kind of a self-stimulation behavior. And this self-stimulation behavior is not because it's a behavior problem, but the child is trying to gather information about the world around the child, and therefore tries to stimulate in whatever possible ways that the child has access to through his own body to get this kind of an information. What about a child who is born blind and who acquires deafness at a later stage? The child is usually raised as a blind child. So communication, especially oral communication, verbal communication is not difficult, but the child might have low vision or totally blind. Depending on that, he might be using large print or braille as reading and writing mechanisms. The child will need help to cope with the decreasing hearing abilities, because hearing till so far has been the primary need for the child, primary mode for the child, might need help in dealing with that. Communication needs adjustment, and there is a change in the receiving mode. He needs to adjust his communication pattern. The child might still be using verbal communication as a primary mode, but his receiving information needs to be changed. So that could be through sign language, it could be through print, it could be through braille. But because a child is having limited access to receiving the auditory information, we need to be thinking of other ways of giving that information to the child. He may need to learn sign language. We don't know, depending on how fast he is losing his hearing, he may need to learn sign language, because he might prefer verbal communication, but if he is unable to receive the communication, then he might get more frustrated and might need to have a more common method of communication, and that could be through sign language. If this child is going to benefit from a amplifying device, from a hearing aid, then that child of course needs the hearing aid and needs proper therapy and intervention to help him use the hearing aid. So, sometimes there are the child might lose hearing due to a genetic condition, and the condition itself predicts a gradual degeneration of the hearing. At that time, it is best to be prepared that the amplification may not help in the long run, and other modes of communication might be more helpful. And here I will come back to the Usher syndrome that I was talking of during the causes. This is a typical, Usher syndrome is a typical condition in which the children are born with some kind of hearing loss and acquire visual impairment later in life. Particularly Usher type 1, the child has profound hearing loss at birth. It comes with associated balance problems. The child will have balance difficulties from the childhood itself, and the vision starts deteriorating at 7 to 8 years of age. This is a genetic condition. You cannot prevent the condition, but you can help the child cope with the condition. And the reason for hearing loss is always retinitis pigmentosa, and the moment you know it is a diagnosis of retinitis pigmentosa, you will know what kind of vision stimulation and support program this child will need. Usher type 3 is relatively rarer, but we still see some Usher type 3 people. Hearing loss is at any time from birth to 7 years. The children, the child is born with normal hearing and normal vision, but any time between birth to 7 years, the hearing loss starts, and the vision deteriorates only later in the adult age. So far we've tried to understand the concept of deaf blindness. What does it mean? Why is it different from multiple disabilities? Why is it different from other disabilities? We've also tried to understand what are the different types of deaf blind people around the world. I've also briefly touched upon some of the major challenges and difficulties they have as an impact of their disability. Of course, the first step of any intervention, beginning any intervention, is assessment. And here we are talking of assessing a very, very difficult group of children, or a very complex group of children, and children with some really complex issues. And therefore, as assessors, our first fundamental rule or the mantra here is that we are assessing the child because we want to understand the child better. First and foremost, we are not assessing the child because we want to fill up assessment formats, we want to document assessment reports, we want to produce assessment reports for our principals and headmistresses. Our assessment process needs to be a process of exploration, understanding, respecting the child, where the child is at the focus of all our assessment. The child leads the way rather than any predetermined condition, predetermined formats that lead the way. And I will explain why I am saying this and how this is still possible. Before we start any assessment for deafblind children, what are some of the key fundamental things that we need to keep in mind when we are talking of deafblind children? Remember that a particular deafblind child has a very wide variety of needs. It is not limited to one or two areas. The impact is more global, and therefore the needs are much more complicated, much more global. Our children invariably show inconsistent behavior. Some days they they perform, or I may say they respond better. Some days they do not respond as well. Therefore, our assessment cannot be a 1 hour or a 1 day event. It is a continuous process. There are variable sensory functions, meaning some days the child sees better, some days the child hears better. The clinical level of the vision or the hearing doesn't change, but there could be other health issues, there could be other environmental reasons why, for which the child is able to use the vision and hearing better or worse on some days. Therefore, assessing the sensory functions in a wide environment across different settings is important. We cannot be using one toy or two toy to be assessing the hearing and saying that yes, my child hears this, or yes, my child hears this much. It needs to be done in a wide variety of settings. Ill health and many other conditions affecting the visually impaired children and additional disabilities and deafblind children, meaning our children have many health issues. It could be heart issues, it could be balance problems, it could be epilepsy, it could be the effect of certain drugs, it could be lack of sleep for days together leading to poor health of the child, it could be bad nutrition, it could be bad metabolism in the body, which can affect the child's behavior. Therefore, any assessment that we need to do, we must first of all, before playing with the child or doing any assessment for the child, we should be very clear what is the health condition of the child. There could be basic perceptual differences between the child and the assessor, meaning the child might be reaching out the hand to say that I want to touch your face, and the assessor, me as an assessor, might be interpreting it as the child cannot hold the toy that I am showing the child, but the child is just reaching out, unable to clasp. Maybe the child can clasp, but more than the toy, the child is interested in your face. So the child is reaching out to you again and again rather than reaching out to the plastic toy. Therefore, there could be differences in what the child is trying to say and what the assessor is trying to look for. We need to be careful what the child is trying to say. Sometimes it is easy to forget what our checklists say and just observe what the child is saying. That will give us much more information about the child. Of course, our children may have very limited attention span. They might not be able to respond to a very long duration of time, and we need to keep this in mind. The child may respond in different ways, making interpretation difficult. As I said, inconsistent behavior, children respond differently each time, sometimes very difficult, which again means, coming back to the same point, that you cannot reach a conclusion by one or two assessment observation sessions. You have to do it again and again over a longer period of time. Medication may have an effect on the responses, particularly if the child is on anti-epileptic drugs and we are doing an assessment at that bad period of the day, then that might have an impact on the child. Always reminding ourselves that we are assessing a child to understand the child better. And if we really mean to understand the child better, what could be more effective than trying to stop, pause, remove all our blinkers and just see what the child is trying to tell us and interpret those results. What might be going wrong even before we do an assessment? What are some of the things that we typically, as educators or therapists, typically do wrong unknowingly? We never do things wrong on purpose, but deliberately. But sometimes as professionals, we tend to be doing these common mistakes over and over. We focus on deficits rather than on the skills, rather than on the abilities. We always talk of what the child cannot do. Always talk of what is his next level rather than what is his current level. We always talk of what the child needs to learn rather than what the child has already learned. Ignoring the child's motivators. We have to do an assessment within a limited time in a particular setting, and therefore we perhaps ignore what's motivating for the child. So removing our assessment observation sessions to the garden might be much more effective for the child, of course, but for us in the long run if we respond to the child's motivators. The pacing is inappropriate for the child. We might be too fast for the child, especially if children have processing disorders, as we mentioned earlier today. The child needs time to be able to receive the information, take it to the brain, allow the brain to process the information, let the brain give a command back to the child, and for the child to show the response. If we move things too fast, if we show things too frequently, then we are completely cluttering the child's brain with just information bombardment rather than waiting for the child to respond back to us. Similarly, the time of the day might be a bad time. If it's a child's sleep time, and children have such odd hours of sleeping that they may not really respond to a assessment session between 11 to 1 o'clock. If the child has woke up at 5 o'clock in the morning, 11 is perhaps the best time for the child to be sleeping. And the materials used, of course, if it is not familiar material, if it is not interesting material, then the child will not respond. And please use different materials for different children, because you don't like to use the same things that other people use. I have my own preferences, you have your own preferences. Similarly, children have their own preferences for toys and other interesting objects. So we cannot have a assessment kit to be used for all children. We have to use what the child finds interesting, perhaps borrow things from the child's own playthings to be doing the assessment. Okay. The task might be too complicated and too challenging for the child. He may not even understand what we are trying to do. Assessments are usually too serious business. It's an assessment going on. The experts have to be there, the files have to be there, the assessment checklists have to be there. But basically the child responds best when the child is playing, and therefore assessments need to be play sessions. Expectation that the child will either pass the assessment or fail the assessment, meaning the child will do what I want the child to be responding, will respond the way I want the child to be responding, or not respond at all. If the child is responding to the same thing in a different way, it's not good enough for me, and therefore the child doesn't know. The assessment tool that we use for the children could be inappropriate, particularly with deaf-blind children. We've seen that if we use assessment tools that have been standardized on children with intellectual disabilities, it doesn't take into account the vision and hearing loss. Similarly, if we are using assessment tools only for the visually impaired children, it doesn't take into account the hearing loss. Yes. Therefore, the tools are inappropriate. Therefore, we need to be using the right tool that is good for the target group, also good for the age that the child we are assessing. We could be doing a complete mimicry of standardized clinical assessment procedures. For example, we are roughly aware of what a pass-along test is, what a Seguin form board is, or what some of the other standardized assessment procedures are, but we are not completely trained to be doing it, or we might be using different material than what is prescribed. I'd say that we have used the right test, but we've completely ignored the rules for using that test. We've actually abused that test for this particular child. So that has and obviously the outcomes will never be appropriate for this child. Lack of a whole child perspective. This is my favorite one. I'm the vision specialist, I'm going to assess vision. She is the audiologist, she's going to assess the hearing. And we all look into our own specialist areas, forgetting, because we have all this multidisciplinary team who is all doing their own jobs, perhaps at the cost of forgetting that the child is receiving all the information, and the responses that the child is giving is all that the child is able to give at this particular time, and that we need to be talking amongst each other. We need to be looking at the whole child and how the child is responding in totality, rather than what are the eyes telling me, or what are the ears telling me, or what are the muscles and limbs telling me. So looking at the whole child. The assessor's blinkers is again what I just explained, that we have our own blinkers on when we are sitting down. We know that we need to be assessing on this particular developmental stage, and therefore we will not look before or after. I know that I am going to assess vision. So even if the child is communicating, is showing anticipation behavior, is showing reaching out and exploration behavior, I am not interested. Follow the child. Now that we've talked about some of the rules or some of the things that we need to be careful as professionals, how can we actually conduct a follow the child assessment? First of all, if we are going to assess a child, consult those who know the child better than you, or who might have a distinctly different viewpoint. I might be the expert, but I still know very little of the child. the family members know more about the child, the classroom teacher might know more about the child, the auto rickshaw driver who drives the child back and to from home to school might know better about the child, the physiotherapist to whom the child is going over the last 6 months might know better about the child. Therefore, before even we try and assess and put our observations on record, let's get to hear what other people know about this child. Identify motivators. Even before we start playing with the child, talk to the child, talk to the family members, watch the child with the family members to know what motivates the child, what encourages the child, what are the child's preferences, what does he like, what excites the child, and that's your weapon. Once you've known what excites the child, what brings a smile to the child's face, what makes the child reach out to a particular sound, that's your weapon. That's how you're going to break into the child's world and understand the child and assess the child better. Match several different sensory inputs if necessary. Sometimes the child may not respond as well to vision, maybe a lot of pressure and a lot of moving and jumping, the child might respond better. Sometimes the assessment says that the child has fairly good hearing, but he may not be responding to the hearing, maybe bright lights, and he might have little bit of light, but he responds better to light, or he responds to particular kind of music. So during an assessment, we need to be matching different sensory information. Even when I'm just doing visual assessment, I might be needing to use a lot of movement, a lot of pressure, a lot of touch, a lot of hearing stimulation for the child, and using all of this will give me the best visual response for the child. Relax or arouse the child. A child who is typically hyperactive, very excited, before even we do any kind of assessment, we might need to calm the child down, quieten the child down, put some relaxing music, rock the child and help the child to relax, and then do any kind of play activity with him. Similarly, if the child is very flaccid, if the child is very dull and or sleepy or not very active, we might need to use a lot of drums, a lot of bouncing and throwing games, a lot of rock and roll with the child to excite the child. Remember, our bio-behavioral states determine our responses. If our mood is off, then
you're not likely to respond.
I will not respond to a chocolate pastry, but if my mood is good, if I'm happy, then I will immediately grab the chocolate pastry. So it's about our biochemicals, it's about a biology that will determine our behavior, and therefore this is about determining what is the biological state that the child is in. Relaxing or arousing the child might be important. Position the child to facilitate function. Very important for children with deaf blindness that sometimes the child might be in a lying down position and may not be able to use the vision as effectively, but if the child is in a half raised position, might be able to use the vision better. Sometimes the child may stand and rock from side to side, and that helps the child to localize the sound better rather than sitting on a chair and responding to your jingles and rattles from different directions.
Oh, I see.
So the children have preferred positions in which they show better behavior. So we might need to know what is the best position for the child. And again, this is not just about deafblind children, any assessment. Allow the time necessary for the child to perceive the stimulus and respond. Just as I said, the children need a longer time to be receiving the information, processing the information and responding. So we need to allow that child that time. Observe for any changes in behavior, not just the behavior that you are looking for, the response that you are looking for. Just observe any change that the child has. For example, you might when you play the drum on the right side, you are trying to look whether the child is hearing on the right side, so localizing the sound to the right side, localizing the head towards the right side. The child may not turn the head towards the right side, but the child, if the child is playing and if the child is cooing and gurgling, the child might pause for a second.
I see.
Which means that the child has heard the sound. Assessing vision of deafblind children, one has to be careful, as in order to assess vision, we can do the following observations. For example, just by looking at the child, does the child appear to have any vision? Is the child looking, observing things? What focusing and tracking patterns are present? Does he look from one end to the other end? Does he look from left to right? Does he look from top to down when he is looking at a picture, or even when he is looking at your face? How does the child use near vision? Is he able to look closely at books or at pictures or at the packet of a biscuit? Is he trying to look closely? And what about distant vision? If he's sitting in a room, is he able to look up if somebody is entering the room? Is he able to look up if suddenly the mother is going from one end of the room to the other end of the room? So how is he using his distant vision? What is observed about the visual field? Is he usually turning his head from side to side, meaning that he is using only the central part of his vision to look from one end to the other end? Or is he usually, when he is walking, is he bumping? He seems to be going in the right direction, but is he bumping on things repeatedly, meaning that he is unable to use his vision looking straight ahead? Does the child look at an object while interacting with it, or look away and then act? So as you just said, that does he look away? You're presenting an object and he's looking away, and you think that he's looking at the other direction, but actually he's trying to focus on the object and then respond to it, and the moment you remove it from the side, he's unable to respond to it completely. Does the child show any color preferences? Does he go only for the reds and the blues, or is he responding equally to the red and the yellow as well as the black and the white? So, and that will determine whether he has any color perception issues. Does the child show preference for movement rather than still objects? Again, he can see, but you need to move the target to catch his visual attention, and once you've got his visual attention, then he is able to focus. But a standing or a stationary object, he may not able to attend to that object immediately. Sometimes stationary things will not bring his visual attention. But if you move your hand, then he will suddenly get to know that you are standing over here, over there. Are eyeglasses or low vision aids recommended? Is it obvious that he is using some of the low vision aids? If he has low vision aids or eyeglasses, is he tolerating them? Is he wearing them? Or maybe his visual status has changed and he is not tolerating them anymore, he is throwing them away. Is it being used currently? And what is a child's preferred learning mode? Does he tend to look at things more closely? Does he tend to hear things and learn better? Or does he tend to look, but he would still touch and confirm the information? Similarly, some of the things that we need to do for hearing screening. Is the child aware of any sound at all? Responds to any kind of sound at all? Does he or she alert to sound? Keeps quiet or looks out at the sound? Orient to sound, looks around to find where the sound is, localize the sound, knows exactly where the sound is coming from, isolate a specific sound in the presence of other sounds, showing preference for the mother's voice in the classroom even when the teacher is talking. So localizing exactly, isolating that particular voice. So, and all of this can be seen through observing the child. They don't necessarily need to have a clinical test to be doing this. These are hearing behaviors that we can observe. Does the child respond to a selected sound among other sounds? So, preference for particular sounds at a particular level. Does the child appear to use hearing to respond during the assessment? Is the child responding more to hearing than any of the visual cues, that is to voice, music and speech? Are hearing aids recommended? Have they ever been recommended in the past? Are they being tolerated? Does the child sometimes use it? If you even see that it has been recommended at some point of time, that itself is a trigger for us to be doing a screening again. If the child is using, then definitely he has some kind of a hearing problem which needs a more up-to-date and periodical evaluation again and again. Any reduction, distortion or absence of distant sensory information affects a children's ability to anticipate. So, both vision and hearing are the distant senses, and any kind of damage, whether it is total loss or any reduction, will affect the child to anticipate, act to changes in the events. Any kind of immediate change in the environment is a complete catastrophe for our children, because they cannot predict their natural environment, and therefore they will become much more destructive, much more withdrawn from the environment. Perceive consistency and structure experiences in space and time. They are unable to perceive the consistency, that when somebody goes, that person is going to come back. So they are unable to perceive that and structure experiences in space and time. For example, at school there will be a lunch time every day. That structure they are unable to understand, even though they have been coming to school every day and having lunch every day, but they are unable to in their mind structure that after 3 periods or after around approximately this much of time or after coming back from outside there will be a lunch time. They will be unable to structure that in their minds. Activities which do not form a part of a child's typical routine or which introduce people unfamiliar to the child may also induce confusion and stress which cannot easily be overcome. So again, it's about they leading a very structured life. Any change by objects, by activities or by people might disturb the complete balance system of the child. And by balance here I don't just mean physical balance, but the balance in their mind about their perception of the world around might get completely disturbed. Activities that they do, the people that they are involved with, the objects around them needs to be very structured. Any change, the child needs to be prepared in advance for those kind of changes. The environment plays a major role in the child's assessment. It's not just about assessing the child, it's about assessing the child within the context of the child's environment. So it must be done in a least destructive kind of environment where the vision and hearing can be controlled in a way. By controlled, I don't mean artificially controlled as in a soundproof room or in an ophthalmologist's chamber only, but where the child has better control, meaning that the child is familiar with if the child doesn't like a particular sound, he has the control to walk away from that sound. If the child doesn't like a particular object, he has the control to keep away that object. So that kind of control is more important for this child. Controlled environment means that there should be control of light and noise. Familiar people should be present and assessment of activities of daily living skills and other skills must be done in the child's natural settings and natural times because that linked. So maybe the child is seeing okay but is not being able to make the link to the sense of touch. Therefore, both if the child is unable to touch and explore and move from mouthing to more tactile exploration, then there has to be a link between what the child is seeing or unable to see and what pressure the child is receiving. Similarly, the child with hearing might have more semicircular canal damage and might have balance problems. Therefore, even if the child is hearing, he may not able to turn towards the sound, towards the source of sound because he has other balance issues. So all these senses are in a way linked together in the brain. Again, at the point about the assessor's blinkers, we can't be doing just our own assessment. In our research says that all the senses are linked. When there is a vision impairment, it's a trigger to be checking all the other senses. If there's a hearing loss, it's a trigger to be checking all the other senses because it's looking at the child in totality. What are some of the other things that we need to keep in mind in assessment? सबसे पहले, what are the child's likes and dislikes? What does the child like? What are his preferences? What is he trying to say? What are the child's tolerances for different types of sensory inputs? Does he allow touch? Does he like rough touch, smooth touch? Does he like a lot of heavy rocking and moving? Does he prefer more gentle rocking? What kind of sensory input the child is tolerating? Does he prefer strong lights? Does he prefer muted lights? All these needs to be matched with the child's expectations. What is a child's willingness to explore new and unfamiliar sensory input? How does the muscle tone affect? So it's not just about vision and hearing, it's also about the full body development. What supports and physical modifications are used and what are the results? So what kind of physical changes are required? And what positioning works better? As I said earlier, that what is the position that works better for our children, that needs to be worked out.